Thank you. I'm Peter Mogayzel from Johns Hopkins University. And with me today I have Lisa Saiman from Columbia University.
Hi Peter, it's great to be here.
And Patrick Flume from Medical University of South Carolina.
Thank you, I'm glad to be here.
This is the accreditation statement for today's activity. You'll be able to get 1 hour of CME credit. To receive credit, complete your post-test evaluation and attestation. Please submit your question by using the chat box. Type in your question to the presenter, click send, and it will be addressed during the question and answer session immediately following our introduction and cases. The learning objective for today's activity are to evaluate currently available data on Pseudomonas aeruginosa therapies, discuss treatment options when first-line chronic inhaled antibiotics fail, and to apply current information to design effective long-term alternating inhaled antibiotic therapy schedules. These are the disclosures for our faculty, and educational support was provided by Gilead Sciences. However, they were not involved in the development of the content. Thank you again for joining us for today's program. We'll be discussing the role of Pseudomonas aeruginosa in CF lung disease, the rationale of inhaled antibiotics, the involving microbiology of the CF lung, and partnership between families and patients. I'd like to start off by giving you some background on the CF lung. This graph from the CF patient registry shows the prevalence of bacteria within the airways. In younger children, Haemophilus influenza and Staph aureus are the most common organisms. However, as people age, Pseudomonas aeruginosa becomes much more prevalent. There are a number of other gram-negative bacteria, as well as MRSA, that are also present. A great deal of focus has been put on treating Pseudomonas infection. This graph is one piece of evidence showing that cystic fibrosis patients that are infected with Pseudomonas aeruginosa have more problems with lung function decline and earlier mortality. This graph is from Sweden, looking at patients with and without pancreatic insufficiency and showing those people that have Pseudomonas have a faster rate of decline in lung function as measured by FEV1 compared to those that don't have Pseudomonas. As we think about infection in the CF airway, there's an abnormality within the airway itself because of abnormal secretions that lead to poor mucociliary clearance, chronic inflammation, and airways obstruction. As people come to clinic, we get cultures on a regular basis. And early in life, there is no Pseudomonas infection. But over time, intermittent infection occurs. And during this period, it's thought that eradication can be performed to try to get rid of or put off chronic infection with Pseudomonas. But eventually, chronic infection occurs. In this early period where Pseudomonas is originally found, or initially found, eradication therapy has been shown to be quite effective. The Cystic Fibrosis Foundation has recommended the use of inhaled tobramycin, 300 milligrams twice daily for 28 days. However, other approaches are likely to be effective. The Alpine study suggests that inhaled azithromycin can be effective in eradication. And because of this approach of eradication, as well as the fact that cystic fibrosis patients are healthier with better lung function, the prevalence of Pseudomonas is decreasing in the population. Failure to eradicate Pseudomonas is associated with worse outcomes. Data from the EPIC trial following patients after initial isolation of Pseudomonas show that 3/4 of the patients, or actually 76% of the patients, received Pseudomonas eradication therapy, and half the patients eventually acquired Pseudomonas. Despite widespread therapy, 40% of patients had increased in exacerbations. They're more likely to have findings such as crackles or wheezes, and they're more likely to isolate other bacteria like MRSA or Stenotrophomonas. There was no difference in lung function or nutritional outcomes, however. The factors associated with eradication are mucoid phenotype of the Pseudomonas, as well as an altered biofilm or defective quorum sensing. Pseudomonas infection is also associated with increased risk for other infections, such as MRSA, Stenotrophomonas, and alkyligenes. When eradication fails, then chronic suppression is used, and this is typically done with inhaled antibiotics. This classic data from the original trials on inhaled tobramycin showed the effect of a 28-day on-off cycle for inhaled tobramycin with a dramatic improvement in lung function initially that's maintained over time compared to the placebo. Azithromycin is the other inhaled antibiotic approved for use in the United States. This data demonstrates an improvement in lung function compared to tobramycin in 3 cycles of the drug. There are other inhaled antibiotics used in Europe, including colistin and levofloxacin. Colistin is also used in the United States in an off-label form. Inhaled liposomal amikacin is also being developed for another indication, but may be effective for Pseudomonas as well. Another approach, rather than using an on-off cycle, is to use a continuous alternating approach of, in this case, azithromycin and tobramycin, with the idea being to preserve lung function during the off cycles where we know that lung function declines. A trial investigating the value of this therapy was attempted. The trial did show some reduction in exacerbation and hospitalization rates. Unfortunately, it was underpowered due to difficulty in enrollment. The challenge was that continuous alternating therapy has become the standard of practice in many centers. This data shows the improvement in lung function that was seen with the initial approach with alternating therapy in the dark compared to just tobramycin every other month in the gray. This data derived from the CF registry that I showed earlier is based on data from the clinical microbiology labs. However, when studies are done looking at the microbiome using DNA or RNA analysis, there are a great deal more bacteria there, and it's far more complex. This is a study looking at individual patients and multiple samples from BAL. Each of the colors is a different bacteria, and the point I'm trying to illustrate is that there's more than just 1 or 2 bacteria in every airway, and that the bacteria change and there's a dynamic change over time associated with exacerbations and aging. There's also an effect of inhaled antibiotics on the microbiome beyond what we see in Pseudomonas infection. This is data on just 2 bacteria that change dramatically with azithromycin treatment. Azithromycin is also used in adjunct therapy. Although it's an antibiotic, the anti-inflammatory properties are thought to be effective in improving lung function, but more importantly, reducing exacerbations. This is data looking at the effect of azithromycin on tobramycin. This retrospective data looking at the change in FEV1 with inhaled antibiotics shows that in those people not taking azithromycin, tobramycin and azithromycin have a similar effect. However, in the people receiving azithromycin, the FEV1 change with tobramycin was less. A large prospective trial called the TEACH trial is underway to confirm this data. The landscape of CF therapy is changing, however. Modulator therapies are now becoming widely used. This data shows that modulator therapy in restoring CFTR function can affect infection. This data from the GOLD trial shows real-life data on the effect of starting ivacaftor on Pseudomonas infection, where 12 and 24 months before starting the drug, approximately half the people were infected with Pseudomonas, where after ivacaftor was started, the infection rate decreased. So in summary, infection affects pulmonary outcomes in people with CF. Inhaled antibiotics are effective in treating people with CF. The airways contain a complex dynamic microbial community, and that CFTR modulated therapies can impact airway microbiology. So now I'd like to start talking about some cases. The first one is a 16-year-old girl who has 2 copies of F508del. Her BMI is at the 25th percentile. Her lung function is good with an FEV1 at the 85th percentile. Her airway cultures have consistently grown Pseudomonas aeruginosa. Her daily medication regime includes Dornase alpha once a day, inhaled tobramycin twice a day every other month, albuterol, as well as oral azithromycin on Monday, Wednesday, and Friday. She uses high-frequency chest wall oscillation for airway clearance and does play sports. She was hospitalized 2 years ago for a pulmonary exacerbation. She's coming into clinic for a routine clinic visit. She typically comes every 3 months. And you've noticed over the past year there has been a gradual decline in lung function. She has a minimal increase in her cough, but really no complaints at today's visit. Before we talk about this case with Dr. Flume and Dr. Saiman, I'd like to have you vote on some possible options for therapy. You could continue the current therapies and have her come back to clinic in 3 months, treat for an acute exacerbation, change her antibiotic therapy regime, add hypertonic saline or other changes to her airway clearance regimen, order diagnostic testing, discuss adherence, technique, or other psychosocial circumstances that may be impacting her care. So why don't you vote now? Thank you for participating. So Patrick, when do you start thinking about changing therapies? What about lung function decline makes you concerned, and how do you approach that?
So I'm always concerned about drops in lung function. What I will say is this is actually a rather typical case. It's not uncommon for a patient to not describe much change in their symptoms, and yet you're looking back at their trend in lung function, and then there is this steady decline. It's a particularly vulnerable time of her life in adolescence, and that's when I think you really need to be most aggressive and recognize that even though it's not been a sharp decline, there is a downward trend. So if there is one incorrect answer on your list, I think it's the do nothing and see her back in 3 months. And of those choices on there, you can get into the discussion about whether I need to light a fire under her to get her doing something acutely or make some changes in terms of what she's doing chronically.
And Lisa, what do you think about this case when you hear this story about an adolescent that's doing well but has had some fall in lung function?
Yeah, I want to echo some of the points that Patrick made, because this is a teenager and presumably she's making transitions to some self-care, and that can be challenging. She's also busy. She's doing extracurricular activities. She's in school. So I am worried about her adherence to her regimen. And like Patrick, I'm really at that decision tree between whether or not she should actually be hospitalized and managed with intravenous antibiotics, because that is a significant drop in lung function, and I am worried she may not get back that full drop.
Now, it brings up a very good point. We know that people that are healthy or have better lung function often get treated. There's often a delay in treatment in those patients compared to people that are sicker. So, Patrick, when you think about this, acute therapy versus changing chronic therapies, what goes into that decision making?
So, and I will again say this is a particularly vulnerable group, because it's those patients who start off with good lung function where things seemingly are allowed to go on a little longer as opposed to intervening earlier. Some of this is related to your relationship with the patient and family, because if you're talking about adding a therapy, you do that at the risk of already dealing with adherence issues and adding something to an already busy regimen. There is something to be said about admission and acute therapy. Not only are you trying to turn things around, but I think you're also sending a clear message to patient and family that these are things that are serious. We're getting lung function for a reason, and if it's dropping, then we should act upon it. Many of those patients may push back. You know very well, they'll say, I hear you, I'm not coming in the hospital. And then you try to find, well, let's figure out what we can do. But of that list, I'd say the most important thing is that you do something and you see them back in the short term to see if it's made a difference.
No, that's a very good point. Making sure that whatever intervention you make actually has some impact is critically important. One of the things that is on that list and we could talk about is changing the antibiotics. So she grows Pseudomonas. Is there value in switching to a different inhaled antibiotic, adding another inhaled antibiotic? Patrick or Lisa, what do you think?
One probably pre-step I would do is really explore what's going on in her life. Like, how is she managing her high school, her extracurricular activities, her social life? Is she taking the medications? Because I would be reluctant to change something when she wasn't taking what she's being prescribed. And I think that conversation has to happen with her parent in the room and without her parent in the room, because this is that transition time where she's hopefully taking on some of her care herself, and that's very challenging. And I also think that it would be really important to make sure she understands each part of her regimen, the rationale for it, what it's trying to do, so that it's a real two-way street. It's not just us giving her the list of drugs without her having a real understanding of what each of them are doing.
No, I think you bring up a very good point. I mean, one of the things that I talk to my patients about is making sure that they're prioritizing their health among all the other exciting, fun things that you can do in high school, and especially as they go off into college, where there's even more opportunities and more stress and more chances not to get a lot of sleep and take care of yourself.
But if we work under the assumption that after your conversation you've decided that she's fully adherent to the regimen that you have her on, then your choices in there are, do I add something, for example, the hypertonic saline, or do I switch something up? So on the one hand, you might want to do more diagnostic testing just to make sure I'm not missing something else. Diabetes, a new organism, ABPA. In terms of the inhaled antibiotics, we do, assuming she's using them, there is an attenuated response to the use of antibiotics, and sometimes making a change will be advantageous. We see the same thing with intravenous therapy, that sometimes patients are less responsive to the drugs that we've been using and more responsive to a change.
Yeah. So that could be that nice decision tree that you bring the patient and their parents in. So here is one option. We could do a hospitalization. That's something that you're understandably reluctant to do because you're heading into finals, it's college application season, whatever was going on in her life. So we could switch her aerosolized antibiotic and see if there was a benefit, but again, a very short turnaround time for evaluating whether or not that's making a difference, so that you would do that anticipatory guidance. If you're not having an improvement, we would have to do Plan B.
So I won't go through the history of how aerosolized antibiotics were developed with the original studies of inhaled tobramycin, but some have questioned whether month on, month off is the right regimen to go through. And one argument for that is looking at that sawtooth pattern of changes of lung function and wondering whether that is okay to let lung function drop again on the off month. Right. And this has led people to move towards a continuous inhaled antibiotic approach, whether to go with continuous, say, inhaled tobramycin, or to actually alternate antibiotics. So go with inhaled tobramycin, change to inhaled azithromycin. And this led to our study of continuous alternating therapy, or CAT regimen. And the argument for rotating was really based upon the early studies of inhaled azithromycin, in which patients who were TOBI experienced were put on inhaled azithromycin and then had an increase in lung function. And so that was our argument. So we designed a study in which we would compare patients who were alternating TOBI every other month, and then would be randomized to do inhaled azithromycin or placebo on the interim months, and to see if there was a difference. The difficult part was we had trouble enrolling patients, and probably the most frequent explanation is that physicians had already adopted a CAT regimen and were unwilling to put their patients into a placebo-controlled study of that. And so we ended up stopping the study early, so we were way underpowered. So we did not demonstrate statistically significant differences, but there were trends, as you had shown in your earlier slide. So although we don't have absolute evidence that that is a preferred or better regimen, what we are seeing when you look at registry data is that clinicians seem to be adopting that practice because more and more patients are on more than 2 antibiotics on a continuous regimen.
Do you think that the registry data will be able to discern whether there's a benefit from doing that as opposed to just staying on one antibiotic?
So what the registry is good at is developing hypotheses, but it's risky to infer that that's the absolute truth. So you could go in there and see which patients are on more antibiotics and to see if their outcomes are different than those on an intermittent regimen. But there are a lot of biases. Generally, physicians are more inclined to push towards a continuous regimen in patients who seem to be sicker.
Treatment bias.
So I think you can tease out interesting observations and hypotheses, but you still have to test them.
And do you consider the additional therapy that's needed, the additional burden, I guess, of doing another therapy? And how do you factor that into talking to the patients?
So that becomes the discussion you have with patients. And again, why it's so terribly important, as Lisa said earlier, to find out what they actually are doing. Mm-hmm. Because if you're adding therapies when they're not actually doing existing therapies, you're not really making progress. So it's easy to talk about adding therapies, but you've got to put that into the context of, well, what comes with it? There's greater cost, there's greater burden. If I'm adding an inhaled regimen, whether it's hypertonic saline or now moving to a CAT regimen, I've added time to that person's day, but particularly if I do a CAT regimen where I'm alternating Toby and azithromycin, I'm using 2 different nebulizers, which could add some confusion, certainly more cleaning responsibilities or educational things. So you just have to try to find out what is likely to result in the best outcome. And that's why engaging conversation with the patient and family is so important.
Do you have any approach to how you might change antibiotics versus the hypertonic saline? So do you have a way of thinking about it, treating the infection differently versus enhancing airway clearance?
Some of that might be driven by how responsive their airways are to aerosol therapy. If, say, for example, she's been reporting that she gets chest tightness or increasing cough when she's using her Toby, I might be a little less reluctant about using hypertonic. On the other hand, if she's a sputum producer, and I will assume that she is, based on the cultures, it might be the very thing that she would benefit from. You know, some patients love a drug like that, and some people just really hate it because it does add to their time and their treatment burden.
Yeah. I think the other consideration here, which I hope would help, is that the delivery system is easier, but she still has to worry about cleaning it and taking care of it if she were to either have alternating azithromycin or just get switched to it, which is something also to think about, like who's actually managing all of those pieces of equipment and making sure that they're being taken care of appropriately.
So I think where we're going on this is that none of those are an absolutely correct response, but doing something is the right thing to do and then follow up on it in the short term.
And the piece about engaging her as a young adult and helping her be part of the decision making, I think will be very, very crucial because as you mentioned, Peter, soon she's going to be potentially out of the home in college, and that's a very, very vulnerable time for a lot of people with CF.
No, I think you're very right. I think this is part of any discussion that you have with patients and families, especially adolescents, is to make sure that you've created a program that is workable, that they agree is going to be valuable, and to try to really institute that is going to be a key to success, because otherwise you're not going to be able to just force people to do therapies.
One thing we haven't discussed is sending cultures. You mentioned it, Patrick, briefly, but we definitely have to explore the possibility that she has a new positive culture for nontuberculous mycobacteria, because it's really a time in life where people in the adolescent age group have a relatively high prevalence of nontuberculous mycobacteria, particularly M. abscessus. So I definitely want to make sure that we explored that.
No, and that brings up a very good point. We get cultures on a routine basis, and we oftentimes find new organisms. So we could rework this case a little bit and talk about this young lady coming into clinic, really doing well, but having another organism, having nontuberculous mycobacterium, MRSA, some other gram-negative like Stenotrophomonas. And the question is, how would you approach that? So maybe before you answer that, we can ask our audience how they might do that. There are several options shown here. One could stay the course, sort of continue the current therapy, immediately attempt eradication of the organism, repeat the culture to see if it's there on subsequent cultures, do additional testing, maybe get a CT scan or some other test that may be helpful. You might change the therapy if they're on, stop macrolides, for example. So let's have the audience vote on these, and maybe we can come back and discuss your strategy. Thank you for participating. So Lisa, in this patient that is doing well but a new organism is found, how would you think about treating this, or would you treat this bacteria?
I think we have to talk about which organism it is, because I think my approach would be different.
Well, that makes sense.
So, for example, if she did have non-tuberculous mycobacteria, I think that would be extremely important to repeat the culture. I think that the data is really emerging to suggest that about a third of people just seem to have transient positive cultures. And again, she is a sputum producer, so we should get a good quality specimen. And then if she were to be repeatedly positive, then it would be really time to explore whether or not there was, as we mentioned earlier, but really double down on exploring whether or not there was something else contributing to her deterioration before launching into treatment. I think it's worth mentioning something, and echoing what Patrick earlier said, there are probably people out there doing or attempting eradication without an evidence base for that. And you know, it's hard enough to design a therapeutic regimen given the multiple drugs and given the potential for toxicity, that I personally feel like we need a better evidence base to support eradication, but certainly would have to document that the organism was still present on a subsequent culture.
Some of this is actually part of the, we're talking about NTM in particular now, about the PREDICT study. It's not an eradication question, but you know, the challenge you have when you have a bug, and let's say it's MAC or abscessus, the question is it doing harm? Is it bad and we should do something about it, like try to eradicate? Or is it possible it's just in there and just cohabiting and it's not actually contributing to disease at all? And the ATS-IDSA guidelines basically give the caveat in the decision to treat is that you've taken care of everything else, which is problematic in CF when you've got bronchiectasis and Pseudomonas and what's the culprit. But the PREDICT study by our colleagues at National Jewish, and now with a multi-site approach, essentially are enrolling patients and observing them to find out what happens in terms of this. Are they intermittently positive or persistently positive, and what are their clinical scenarios, until they achieve some clinical features that suggest that treatment is warranted, at which time they're enrolling them into the patient's trial, which is not a comparative trial as much as it is trying to find out how well a regimen works and beginning to identify what the outcomes are. And I think this is a fabulous approach because we don't have that epidemiology to know whether it's the right, what's the right thing to do. So if you were to say, let's embark on a eradication strategy, what do you do if half your patients have a negative culture the next time around anyway? How do you interpret those results?
Exactly. Yeah, and just to, the nice thing about what's happening with those trials is I think they're going to teach us a lot about how to approach other problematic pathogens or microorganisms that may not be pathogenic in every single patient when you recover it from a culture. I think MRSA has similar questions around it. Again, a substantial proportion of people don't have persistently positive cultures, and I think there was an effort made to come up with a regimen to do eradication that was quite onerous and didn't show any long-term impact on clinical benefit. And I think that we still don't know the optimal way of treating MRSA when we think it's contributing to an exacerbation. But you know, again, there are ongoing studies to help us learn more about that.
Well, one thing I think we all can agree on is that in terms of Pseudomonas, everyone believes it's a bad bug. And the state of the art is to treat it, whether by eradication, as you described earlier, for early infection, or chronic suppressive therapy. So it's a legitimate question to say, should I do the same thing for any other bug that I grow, whether it's staph, whether it's MRSA, whether it's Denotrophomonas or others. So I know people are doing it. Whether it's the right thing to do is still debated. But at least MRSA has got attention because looking at registry data, you do find a compelling hypothesis that MRSA is associated with worse outcomes. Now what we have to do is demonstrate that either an eradication approach or chronic suppressive therapy results in better outcomes. And the STAR-2 study was looking at an eradication effort. And there is a study looking at aerosolized or inhaled vancomycin to see if it will result in clinical benefits. I think the main key is that we need to investigate it, not just adopt it until we have some evidence that it's actually going to make a difference.
No, that's, very, very true. We have a tendency, as you say, to do more stuff because we want to make people healthy, but it's not always clear that we need to treat particular infections, or if we do need to treat them, exactly what the optimal approach is. So really doing some investigation to figure that out is going to provide valuable insight. I did want to touch on one thing about NTM as we talked about it kind of generically is, do you think about NTM differently if you're talking about abscessus versus MAC, or is it all the same?
So abscessus has gotten a lot more attention in the CF world for a few reasons. One is it seems to be more prevalent in the CF population, whereas in the general population, MAC is far more prevalent than abscessus. And secondly, people think it's a worse pathogen, even to the point where some patients may no longer be eligible for a lung transplant. Though the guidelines say that should not be a contraindication, it may still factor into some decision making. And so I can understand why people would want to take a much more aggressive approach when they first find it. Having said that, we don't have uniform screening that's going on across the country. There are some centers that are actively screening for NTM, whereas others, it hasn't become a standard approach, much like bacteria. Now that's changing.
It is recommended in the guidelines, of course.
So that may increase, and then we'll find more patients that have it. But I have heard, again from our folks from National Jewish, that they are equally worried about MAC, that they are seeing patients who seem to have worse outcomes in the presence of MAC. So their message is, don't just get your attention on abscessus, pay attention to NTM in general.
Yeah, and I think that the guidelines have very similar, the treatment regimens are of course different, but the approach is the same, that you have to confirm that it's really there, and then assess the clinical picture, make sure you've looked at all those other potential contributors to deterioration, and make a well-informed decision. Because the treatment regimens are quite onerous, and in the case of M. abscessus, it requires intravenous therapy for quite some time with a lot of potential toxicities. So you really have to make sure that you have made a very sound decision for the patient's sake.
So one of our questions was to stop the macrolides if you do find a culture that has NTM. Would you agree with that?
Totally.
As the
macrolide antibiotics are really the workhorse of the regimen. And there's emerging data that macrolide resistance does occur. There are intrinsic mechanisms of resistance that get induced in the presence of macrolides. And we need to know that because the patients will not respond. So it's crucial to do that. And there are many patients that, despite taking macrolides regularly, still have susceptible non-tuberculous mycobacteria, but it can make it a much more complex regimen if you lose that drug.
So let me throw something into that mix. First off, everyone I think is going to agree with it. The guidelines are pretty clear. Most of that literature is driven by MAC, that when monotherapy of the macrolide is used, you do select out resistance, and those patients have worse outcomes. Not in the CF population, that was all in the non-CF patients. But with abscessus, a large proportion of them are already macrolide resistant. Right. So one could ask, is it really doing anything? Now, part of that is if people generally aren't getting susceptibility testing that informs them about whether or not the bug is macrolide susceptible or resistant. And that's particularly important with abscessus because it's an inducible resistance. So standard methodologies aren't going to detect it, and you should do gene testing to look for that. And that's something I think we do have to get into routine practice, as well as identifying subspecies to make sure people know which bug they actually are talking about.
Yeah, it turns out that there are 2 or 3, depending on who you talk to, subspecies. It kind of reminds me of the Burkholderia story when we've suddenly learned that there are dozens of Burkholderia species that are part of the Burkholderia cenocepacia complex. We've now learned that there are multiple species. But one sort of mini advertisement here for the listeners are to make sure that they make friends with their clinical microbiology laboratories and mycobacteriology laboratories to really be informed about how the specimens are being processed, because as Patrick mentioned, it's important for both identification as well as the susceptibility testing that it be done. And the guidelines are very complete with regard to how it should be done, so they can be shared with the laboratory personnel.
And there is a program sponsored by the Cystic Fibrosis Foundation in which these organisms can be sent to the National Jewish Laboratories for further investigation.
Let's just move on to one other case. Taking our first patient that came into clinic and had a decline in lung function, there were a number of interventions that could be made. Does your approach to this patient change at all if she's older, if she's an adult, if her lung function is lower, 40%, 50%? Do you approach this a different way? So before you give me your thoughts, let us ask the audience the same questions we asked before. If the patient is an adult with a lower lung function, would you just continue the current therapy? We know that's probably wrong because Dr. Flume said you should never do that before. Treat for an acute exacerbation, change the antibiotics, add hypertonic saline, do other testing, or discuss adherence and other aspects of life that may be impacting what's going on. Thank you for participating. So Patrick, what are your thoughts about this older patient?
So the short answer is the strategy doesn't change. If there's evidence of decline, that's just not acceptable to let it continue and intervention is warranted. Some of the questions and issues are different, perhaps. You have a 16-year-old adolescent, busy in sports and school, taking on independence, just wants to be a teenager, right? Now you have an older patient, might be working, might have a family, children, other responsibilities. And so you might come in and say, well, we need to intervene. Let's talk about being in the hospital. And she might counter with, I have kids at home, I can't do that. Mm-hmm. So you got to find, well, what is working and what isn't working. I will sometimes argue that it's valuable to put people in the hospital. And I am one who tends to believe that intervention in the hospital is superior to intervention outside of the hospital. And even though many of those therapies can be done at home, the point might be, I need to put you in the hospital where you have nothing to do except pay attention to your health. Right. You'll be bored out of your gourd, but you're going to be focused on just getting better. Because I just assume people are like me. I have many distractions. And I can find reasons to do other things and not do the things I should be doing. So it is kind of a reset, a wake-up call. But I do think you need to probe. There might be other issues, depression or anxiety, right. Financial issues that need to be factored in terms of any of those treatment decisions.
Yeah, I would really echo that. And I think that we're really understanding that anxiety and depression in both individuals with CF and their moms more than dads is so prevalent, and big initiative to try to cope with that, but really crucial. I would be, in this setting, I think I'd be more likely to hospitalize her than the first case. I might have been in a different place, but I am worried. 25-year-old people should actually, that's not such a great lung function at all. And given the fact that she is probably very, very, very busy, adherence is, I'm sure, really being challenged. So I do like the concept of a reset that you described, and understanding, like almost not taking for granted that she knows how to do everything, and really revisiting all of the airway clearance techniques, and again, making sure she understands the importance of each and every drug. And the data really suggests that even when people say they're taking all their medications, they're honestly not. You can tell that by prescription refills or what's actually when you really probe deeply, being said in a truthful way. So I would assume that the person is not able to manage the entire regimen, particularly if she had kids, as was hypothesized here.
No, there definitely are challenges that are different, but certainly still very, very important as you get older. One thing I wanted to just touch on as we were talking about antibiotics, does age and severity of disease and the idea of more resistant bacteria change your approach to inhaled antibiotic therapy?
You know, it's such a loaded question, Peter, because we are, as an infectious disease doctor, I think of resistance in a very different way in non-CF patients. And in CF patients, the susceptibility panels that come back from the laboratory are really not that meaningful, as it turns out. And we've known that for a long time, that people will get better on a regimen that the susceptibilities say, well, resistance, and then in contrast, not get better or not eradicate the organisms on a regimen where you see all S's. So I think that it's clear that the laboratory testing, what we call the in vitro susceptibility testing, doesn't really help us that much in terms of clinical outcomes. And when you give a drug by the aerosol route, you're getting such a big concentration of antibiotic within the lung, targeting the site of infection, that oftentimes you're able to overcome the resistance mechanisms. But again, we're really confronting such a complex ecology where the mode of growth, which we think is a biofilm, where the nutrient supply, which we think is not great, it's probably also like a relatively anaerobic environment, really challenges the activity of antibiotics. So this is an effort that Patrick is leading now. It's an international effort that you might want to tell a little bit about.
So it's a program dedicated to trying to get a greater understanding of antimicrobial resistance in CF and inform all of our stakeholders about the current existing knowledge. So on the one hand, I think from a resistance perspective is that it's important that there are bugs which are inherently resistant to an antibiotic and those which are not. That's useful. The issue in CF is how informative the culture result is at telling you that, because there's all kinds of reasons why the drug might not work in a patient population, and that goes for systemic therapy as well. So where cultures are helpful, as we discussed earlier, is perhaps identifying genus and species, so if you have a new pathogen, but it's not as predictive in terms of the susceptibility and the response. So in a patient like you're describing, if they're on a therapy and something's not right, then the reason to switch an antibiotic or to move to a different regimen, like a CAT regimen, is because they're not responding clinically the way you would hope. And so you do the test. You give them another drug and you see if there's a different response. So it wouldn't be, as an example, if my culture shows a highly resistant bug to tobramycin, that wouldn't be what drove me to change the drug as much as you're just not getting better. Because let's say the bug is resistant to azithromycin. That wouldn't prevent me from using inhaled azithromycin in that patient to see if there's a clinical response. It's not an easy concept for most people to grasp, but that's what empiric observations have taught us over time. And so that's a much more practical approach to managing those patients.
I should add that what I think is going to be really important that's coming out of this initiative, which is an international initiative being conducted around the world by CF investigators, is developing a shared vocabulary with sort of case definitions for what is resistance, what is susceptibility, so that we can really be able to talk about these things in a much more meaningful way.
No, I think that is going to prove very valuable because, as you say, the in vitro susceptibility and how that plays into clinical efficacy is not clear-cut at this point. We're talking about changing therapy or adding new therapy. How does radiology testing factor into your decision to do something different?
So in the list of responses, we had diagnostic testing. and looking for other explanations for why a person is declining. Diabetes, ABPA, but when you're worried about bad mucus plugging, so that areas of the lung are sort of lost to you, or the presence of a new organism that you might not be getting by sputum cultures, that's when CT scanning, I think, is very helpful. Much more helpful than a chest X-ray, unless I heard no breath sounds coming into a certain area of the chest. Because if, for example, I think I need to go to a more invasive approach to identifying a bug, so doing bronchoscopy, so perhaps they're non-sputum producers, or I still am worried that nothing else I've done is working, then I would get a CT scan, because that might tell me exactly where I should be targeting, where I should go with the bronchoscope to try and identify something.
You don't routinely get CT scans, or do you think that has value as well? I
do not get a routine CT scan. It's not like we get CT scans every year on our patients. It's typically clinically driven. When a patient is just not responding like we would think, or in the adult patient, sometimes when they have new onset acute chest pain, you sometimes can find things that might explain that, such as a obstructed segment, which is you really need to focus on with airway clearance, or be aggressive with hypertonic sealing, or even bronchoscopy. Occasionally you'll find loculated pneumothoraces. Fortunately, that is rare. But those are situations in which CT might be advantageous.
No, I agree. We tend to have a very similar approach of when things aren't going the way you expect, or finding new organisms, to really try to identify sort of unsuspected problems.
I'm sure it's one of those areas of sensitivity for patients and families about radiation exposure, so you have to really have a sound rationale for why you want to do it, and explain it's going to be done as safely as possible.
Actually, I feel like I don't get much concern or pushback from our patients, which is very different than if you were adopting a routine CT scanning in a child as part of your routine practice of monitoring. Fortunately, the Australians have shown us that that wasn't critically necessary to best manage your patients.
Probably means you're doing a great job explaining the rationale.
That could be.
One of the topics that I mentioned in my introduction, but we really didn't touch on, is azithromycin, and the use of azithromycin in people that grow Pseudomonas as an adjunct therapy, and the relationship between azithromycin and the effectiveness of tobramycin. Lisa, how do you advise people about using azithromycin?
Well, I'm just glad the TEACH trial is ongoing now. I think that that's been really important to do, because there were observations doing post hoc analyses of the comparative trial of aerosolized azithromycin, aerosolized azithromycin and aerosolized tobramycin, where there really did look to be an adverse effect of azithromycin in the people that were on aerosolized tobramycin that wasn't noted in the study group of azithromycin and azithromycin. And then the team went on to show that there's biologic plausibility to that observation, because it looks like azithromycin actually stimulates the production of efflux pumps that pump out the aminoglycosides, so that would make it less active. So the TEACH trial is really going to be helpful, because people will be randomized and will be able to see if those in vitro effects paired with the post hoc analyses are consistent in the trial, in which case we would have to change the way we approach those regimens. And to me, and it's something that Patrick and I have actually talked about together before, it's so important to take these looks again at these long-term therapies. So these were randomized, placebo-controlled trials that showed us that those drugs were of benefit to people with CF, and everybody that fulfilled the inclusion criteria was put on those drugs. But we need to continually ask ourselves these very hard questions about long-term benefit, unanticipated adverse outcomes, things like that.
So I think the important part of the TEACH trial is you make observations in the laboratory, you find compelling clinical data that are fitting with that story, but you still have to do a study to try and find out if you can't just say, oh, well, that is the case, so I have to stop these therapies, because the macrolides have been beneficial. Now, whether they are working by an antibiotic effect or an anti-inflammatory effect, we can debate ad nauseum, but the reality is a clinical trial was done, Lisa, that demonstrated a clinical benefit in a reduction in exacerbations, which is, perhaps the most important effect to patients. Subsequent to that, there was concern about using chronic macrolides and perhaps increasing the risk of mycobacterial infection because of laboratory data. But the observations using the registry is that suggest there's a protective effect. And so, there's no perfect drug. There's always benefits and potential risk. But I look forward to getting the results from the TEACH trial so we can know a little bit better about how best to use these drugs together.
No, and I think that brings up an important point, that we treat people with a lot of different medications, and the interactions are sometimes unknown and how they're going to work over long periods of time. So really studying it and not just assuming that things are going to continue to work the way you anticipate from an early trial is very important. Lisa and Patrick, thank you for a very interesting discussion on infections.
You're welcome. It was fun.
Thank you.
We'll now answer a few questions from our audience.
We will now move to the question and answer session. If you have any questions, please type them into the Action Center, and they will be addressed in the order in which they are received. Peter, the floor is yours.
We've had a number of very interesting questions from our audience. The first one is about modulator therapies. We have a number of new drugs that have come onto the market and future ones in development. And Patrick, what's been the information about how the modulators may affect the bacterial environment, and perhaps how you would think about changes that we've seen on future therapies or the way we approach infections?
Well, thank you. So the CFTR modulators have been very interesting. Obviously, we're happy to see them work for our patients, improve lung function, but we're seeing lots of other clinical benefits. And one of those is the other impacts of the lung, like improving mucociliary clearance, but also the potential effects on the microbiology that we get from the cultures that we get. And actually, early on, we're beginning to see those numbers are evolving. And so I think over the next several years, we'll see some real interesting changes in terms of which patients have chronic infection or time to first infection, and there'll be a lot to talk about there. On the other hand, I don't know that it really should influence how you make decisions in terms of therapy. So whereas your patient, as you put them on a modulator, might be asking what therapies they can stop, if they still are growing Pseudomonas in their cultures, I'm not sure I would advise them to stop their inhaled antibiotics. And so for me, the decision about how I use those antibiotics and in which patients is still based upon their clinical status and the microbiology.
Now that makes a lot of sense. Lisa, do you think that we'll be seeing changes in the whole population as these drugs are used in younger and younger patients?
Yeah, excellent question, obviously, and I think we just need more time. We're poised to do those studies, and that's incredibly important. So there is a study that's ready to go, to be deployed, called PROMISE, where there will be all of the things that Patrick just mentioned, not only looking at things like mucociliary clearance, but looking at changes in microbiology over time. And what you're saying about the younger child is very important because they won't have established infections. So it's probable that the impact of the CFTR correctors will be different depending on when they're begun. So in the young child, they may never get infected. We may have a substantial delay before infection. And in people that already have established lung disease and infections, we're not 100% sure. Will they lose those infections or not? But I think the best news is that we're really poised to be able to answer those questions.
So one of the challenges that I think providers often face is how to interpret resistance patterns in Pseudomonas in particular when thinking about using inhaled antibiotics. I know, Patrick, you've done a lot of work or given a lot of thought to resistance and how to interpret those numbers. What do you think we should do with respect to inhaled antibiotics?
So there's a lot that we know empirically about resistance, and I'm not sure that we have all the answers to explain our observations. But classical teaching would be that if your bug is resistant to the drug you're using, that you would not expect a clinical response. But our experience in CF is that we see patients who harbor resistant organisms improve in spite of it, or sometimes patients who seemingly have susceptible organisms that aren't responding to those therapies. And so we often find ourselves shifting those medications around. We have a working group addressing this, and we made our first presentations at the last North American meeting about the progress from the group. And I'm pleased to say that our second manuscript has been accepted for publication and is now online in the Journal of Cystic Fibrosis, which was a systematic review of the literature to demonstrate the prognostic ability of culture data in response. And the reality is that it's not. What will be forthcoming is the consensus recommendations on how to use those data. And it's not that physicians aren't interested in tracking resistance. They're more interested, though, however, in the species, which bugs are present in the sputum, and the clinical response. So with more specificity for your question, if I, for example, have a patient with Pseudomonas and that bug is resistant to tobramycin, that would not deter me from using a drug like inhaled tobramycin in those patients. And our experience is, in general, those patients will respond. So I think probably the most valuable of information is the species results, and then we will find out again, soon, I hope, more about how to use resistance data. But as a practice, our center is actually ordering susceptibility testing less and less as time has gone on.
Peter, I'd like to also add that the audience needs to understand that the breakpoints, like the number that we use to determine if something is susceptible or resistant, is based on bloodstream infections and also based on the concentration of an antibiotic that can result in toxicity, such as nephrotoxicity or ototoxicity in the example of aminoglycosides. But those parameters and those paradigms are not relevant when you're giving a drug by the aerosol route, where you're giving much, much higher concentrations that can overwhelm typical mechanisms of resistance and are not associated with systemic absorption and the toxicities that I just mentioned. So that is another really good reason why we shouldn't make the correlation between the resistance determination that we get from a microbiology report and whether or not a drug is going to work when given by the aerosol route.
No, you make a very good point, Lisa, and I think we sometimes forget exactly how these values are obtained by the microbiology lab. I think that we'll need to wrap up our questions, and this has been a very helpful discussion for our participants.
Thank you for participating in this program. To receive CME credit, complete the post-test and evaluation forms. I want to thank Lisa and Patrick for participating in this really great discussion.
You're welcome. It was fun.
Thank you.